My talk today is about ingested foreign bodies. It's a little background on it. Generally speaking, more than 80% of just ingested foreign bodies pass without having to do anything. Obviously, more so for like the psych patients, the mentally ill, or like prison patients, that statistic goes down pretty drastically. Most commonly speaking, for adults, when they come in, it's usually for food boluses, and for children, it's like toys and coins and stuff. Demographically, the patients that kind of come in are more so at the extreme, so it's going to be like either the really little kids or the mentally challenged older adults. As far as like where the things get stuck, usually it's in like 1 to 3 places. Usually it's like at the upper esophagus, at the cricopharyngeus, or it's at the level of the aortic arch where it kind of crosses over the esophagus. And then number 3 is at the diaphragmatic hiatus, which is essentially the lower sphincter. And why we care, it's more so because of the complications, obviously, things like airway compromise, lacerations, perfs, obstruction, and I suppose a little down the line strictures that can develop as a byproduct of all this stuff. And how do we catch it? With adults, it's more easy. They'll tell you like, oh, I ate something, it feels stuck. They'll complain of stuff like pain, dysphagia, and if it's a lot worse, then they'll have like an inability to protect their secretions. With kids, it's a little harder because they won't really say. They won't be eating. They'll be throwing up. I suppose all these things kind of also go along with the psych patient or the mentally challenged, just because they won't really be able to tell you exactly what's going on. While all this stuff is going on, also do keep in mind that you're also evaluating for stuff like perfs and obstruction. So and I guess airway stuff. So fevers, peritonitis, stuff like that. Diagnostically, it's pretty straightforward. If they tell you like, oh, it's like a coin or like a battery that they swallowed, just go with the X-ray and you're done. For coins or like flat things, generally speaking, the AP film is usually the way to go. It'll kind of be sitting in the coronal view, so it'll be similar to the one on the left. If it gets stuck in the trachea, then more so like the lateral view help you out better. But if you don't catch anything on the X-ray and they say like, oh, I still feel like there's still some stuff left, still some things stuck, the sensitivity for CT is like upwards of like 99%. So for the most part, you'll catch like most everything. Now management, it's kind of dependent on a few things, like the type of object that they swallowed, where is it at, and just how they look clinically. And so it's kind of broken down into a few categories as far as how to manage it. Number 1 that we'll talk about is food boluses. So this is probably what we'll see most commonly in our EDs. Generally speaking, unless they have some sort of like airway stuff or like obstructive stuff that's going on, medical management is usually the first way to go. It's kind of questionable how effective it is even at all. Glucagon is usually the first way to go. The whole idea is that when you give it, it kind of relaxes the esophagus so that the food can pass through a lot easier. But the studies have just been like all over the place as far as like if it even does anything at all. But just do keep in mind that if you're giving it, one of the side effects is actually vomiting, so it can actually make the problem worse. So, it might be worthwhile to give like an antiemetic before you do so. With sodas, it's like a similar idea where the carbonation actually just tries to push open the esophagus so that it facilitates passage. Obviously, if the thing's still stuck in there for like greater than 12 hours, then you call GI to come in and get the thing out. Number 2 is our button batteries. They're more so, this happens more so with the kids, obviously. This is a very hard indication to get an emergent endoscopy. Within the esophagus itself, if it's stuck there, burns can start happening as early as like 15 minutes, and they'll perf as early as like 6 hours. So they really need to come out. But if by chance when they come in, you get the plain film, it's already in the stomach, then you can just watch them. For the most part, once it gets through the esophagus, it just passes through pretty quickly. So it's really usually not a problem at all. The next category is blunt objects. This includes stuff like coins. For the most part, if it's in the esophagus, it has to be plucked out because most of the time they're symptomatic as well. But if it makes it through to the stomach when you first see them, it usually does pass. It usually does pass through. But if it's greater than 2.5 centimeters, then it might have a harder time to pass through. So, by that point, typically, the patients are asymptomatic, so you just have to follow them with a weekly radiograph just to ensure passage, and you can tell them like, oh, like look in your poop. If like the thing's there, you can stop coming in. However, if the thing still stays stuck in there for like a month, or if it's distal to the duodenum and still stuck in there for like a week, then either GI will go in to pluck it out, or else it'll have to be like cut out by surgery. So, just something to keep in mind with blunt objects. With long objects, what they categorize as long as stuff that's greater than 6 centimeters. These all require endoscopy, and for the intermediate length of an object, which is categorized as like 4 to 6, these can actually pass through the intermediate length ones, but up to 50% become impacted in the ileocecal region. So these intermediate length guys also need to get the serial radiographs to kind of just watch it go through, or else it has to be cut out. With sharp objects, this is another hard indication for emergent endoscopy. Part of the concern is obviously perfing. So with stuff like chicken bones, fish bones, glass, like these have to come out. Unfortunately, sometimes when it gets stuck in the esophagus, just logistically, it's not feasible for them to go in to pluck it out. So in those circumstances, they admit them, get daily radiographs, and if after 3 days it's not really passing through, then they call surgery because it might have to just be cut out. But if it's been in there for a while and there's already like some sort of abscess formation, then you just forego all the GI stuff and just call surgery right away, just because of the perf through the lining of the esophagus. So I guess all in all, these are just the indications that you have to know. Emergently, at the very least, just know that if they're obstructed, it's a button battery, or there's a sharp object in the esophagus, you have to call GI right away, like over daytime or overnight. For the other stuff, you can like hold off a little bit. It just has to be taken out like within 24 hours. So food impactions, blunt objects, sharp things in the stomach, or long objects within the GI tract. Disposition-wise, pretty much all these can go home. I guess as an aside, for food impactions, generally the ones that we'll see when they get stuck, like there's usually something pathologic going on, because most people don't get food stuck in their esophagus. So these guys need to get follow up with GI so that they can go in and try to figure out what's causing these issues. So, but all in all, everyone leaves once it gets plucked out or it just passes through the tract. So that's it.